Welcome back to Government School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing Internal Medicine Competency 1.14 Jugular Venous Pulse. The jugular venous pulse is the most informative physical sign in cardiovascular medicine. That is one point. So it's most often confusing. I will make it simplified in such a way that at the end of the session you'll be able to correctly identify the JVP and measure it and identify the abnormal waveforms in the JVP. That is the agenda today. First we will start with a few anatomical principles. So the JVP is a representation of the right atrial pressure. So this is the ventricle, this is the atria, and as we know this is perivenous cava. The changes in the right atrium pressure is reflected inside the venous system, and that is what is we measure as the jugular venous pressure and pulsations. During systole and diastole, changes in the pressure in the right atrium occurs, and that is what is producing the waveforms. And we see the anatomy a little more detail. So here you can see this is the superior vena cava formed by the right and left. This is the right brachiophallic, the left brachiocephalic, and this is the right one. And here you can see it more clearly. So this is the left brachiocephalic. This is the right, the internal jugular vein combined with the right subclavian. And this is the external jugular vein connected with the right subclavian. This is the anterior jugular vein. The surface marking of the internal jugular is important. It's from the earlobe to the sternoclavicular joint. So that is surface marking. The external jugular is from the earlobe to mid-clavicle. So this is the basic anatomy that you should remember when you are examining the jugular venous pulsations. So now we go into how to examine the JVP. That's the most important part. The patient should be reclined 45 degrees. That is the correct position. Incorrect positioning is the commonest cause of error in JVP examination. Again, here you should remember that if the JVP is visible in the sitting position, there is no need to make the patient lie down. So in simple terms, you can say that the JVP should be examined in whichever position it is best safe. Hope this point is clear. So the JVP is not visible in the sitting position, you make the patient 45 degrees and always see that the head is supported with a pillow. So recline at 45 degrees, head turned slightly and neck is relaxed, supported with and if you want you can throw a light also. A torch light can also be applied, so there should be good lighting. And you should use two scales to measure the height of the JVP. And again, how to identify? It lies between the two heads of sternocleidomastoid. So this is the position between the clavicle, the sternal head and the clavicular head. In between lies the internal jugular vein. And if you draw a line like this, is the position of the internal jugular vein. JVP must be seen, but don't try to palpate it. Look don't palpate. That is the rule for the JVP. JVP is better seen than felt. Usually the right internal jugular vein is selected because it is in more direct continuity. And external jugular vein is not usually routinely used because it passes through different facial planes. It has got valves. The internal jugular vein has got no valves. That is why the internal jugular vein is selected. Confusing the carotid for jugular vein is a common problem. So how to differentiate a jugular venous pulsation from carotid pulsation? So most important, JVP is sinus in nature. At least two waves are there. This is a wavy. It is better seen than felt. It changes with the respiration and other maneuvers. It can be obliterated with pressure. And again, in addition, you can see that the JVP collapses inwards. In comparison to the carotid pulsation is a expansile pulsation. And JVP has got a definite upper level. So these are the points by which you differentiate a carotid from jugular. So it's an expansile single pulsation. It is palpable, doesn't change with the respiration, it is not obliterated, and it usually don't change with the respiration or other maneuvers, and there is no definite upper level also. So this is how to differentiate between carotid and JVP. Then how to measure it? As mentioned, two scales should be taken. You identify the highest point. One scale is kept horizontally and the other scale from the sternal angle keep it vertically, and this height should be the one which you measure. This is the one you have to measure. Hope it is clear. So measurement of JVP is the core clinical skill that you should have. So identify the highest point of venous pulsation, measure the vertical height above the sternal angle. So this should be the one. And again see that this is parallel to the ground. And what is a normal? Normal is less than 3 to 4 centimeters. The vertical height above the sternal angle is the true measure of the JVP. A JVP above 4 centimeters is normal. So this is how you measure the JVP. You measure it from the sternal angle. And as again I have told you, if the JVP is visible in the sitting position, you can directly take the measurement. That's another. Whatever be the height, you measure it directly and see what is the height. Okay. Now we go into the waveforms of the JVP. As mentioned, JVP is sinus in nature. And remember, the A wave is due to the atrial contraction. So we will draw this is the ventricle, this is the atrium. So the JVP, the first, this is the A wave. It is due to the atrial contraction. The atrial contraction occurs at the last part of the ventricular diastole, and 1/3 of or 30% of the blood entering the right ventricle or ventricles are due to this atrial kick. And following this, the ventricle contracts or the ventricular systole occurs. This produces closure of the AV valves, and that is the S1. During this time, the tricuspid valve bulges into the right atrium, and this produces a small wave called the C wave, which is not normally visible. Usually, it's not visible. Then, during ventricular contraction, there is a pulling of the tricuspid valve. The pressure in the right atrium declines and thus produces the X descent. So now remember, this is the systole. The semilunar valves are in the closed position, which is opening due to the ventricular systole, and the blood is ejected in the pulmonary and the aorta. And during this time, blood is entering the right atrium through the superior vena cava and the inferior vena cava. So blood is entering the right atrium. The AV valves are closed. So pressure inside the atria increases, and that produces the V wave. So what is V wave? V wave is due to the continuous filling of the atria that occurs during ventricular systole. Hope it's clear. So this is the V wave. Now the ventricle has completed the contraction and is going to diastasis. So the semilunar valve closes because the blood tries to enter the ventricles. The semilunar valve closes, and that causes the second heart sound. Now the ventricle is relaxing. The pressure inside the ventricles comes down. So what happens? The AV valves opens. So suddenly the pressure inside the right atrium comes down, and that is represented as the Y descent. So hope you understood the JVP. So this is the A wave due to atrial contraction, C is due to bulging of the tricuspid valve, and the B wave is due to the continuous filling of the atria that occurs during ventricular systole, and then the Y descent. So here comes the S2, and here comes the S1, and this is the period, this is the systole. So this is the basic thing you should remember regarding the waveforms. Now we look into some of the common abnormalities in the JVP. A waves are absent, as we know it is in atrial fibrillation. A giant A wave can occur when there is a tricuspid stenosis. So the valve is stenosed, but the tricuspid stenosis by the time produces atrial fibrillation. So the most common cause for a large AVV is pulmonary arterial hypertension, any condition that produces PAH. That's the mechanism. In pulmonary arterial hypertension, the right ventricle gets thickened. So it is less compliant, and so right atrium has to contract more forcefully. So any condition that produces PAH can produce a large A wave. A prominent V wave can occur in tricuspid regurgitation. So in tricuspid regurgitation, what is happening when the ventricle contracts? Blood enters the right atrium. So this is the A wave. Instead of the C, what happens? You get directly C and B combined together forms a C wave. You get what is called a CV wave in tricuspid regurgitation. Hope it is clear to you. So A wave absent in atrial fibrillation. C and B wave combined together, you get in tricuspid regurgitation. The two additional findings you get in TRR. One is a pulsatile lever, second is a systolic murmur, pansystolic murmur that increase with the inspiration. Now we go to cannon wave. What's a cannon wave? Cannon waves are nothing but large A waves which are produced due to contraction of atria over a closed AV valve. So they occur when the AV valves are closed, and during that time atria contracts. What is a co-contraction? There can be two types. One is a regular cannon waves and another is irregular cannon waves. So in irregular cannon waves, the typical example of irregular cannon is a complete heart block. Complete heart block is the typical condition. So in complete heart block, what is happening? Atria contracts at around 78-72 per minute. Ventricle is contracting again regularly, but at a slower rate around 30 to 40. At times they come together, and during that time you get the cannon wave. So as told, cannon waves are due to co-contraction. So the most important condition you should remember is the complete heart block. So irregular can occur in ectopics. Suppose the ventricle, a premature contraction is occurring, irregular, so you can get a regular cannon waves. You can get, suppose, a junctional rhythm. That is, the impulse is originating in the junction. It activates the atria, it activates the ventricle simultaneously. So what happens? Each time, during each contraction, atria and ventricles are contracting together. So you can get co-contraction and produce a regular cannon wave. Hope it is clear to you. Now we think about the hepatojugular reflex. You apply firm pressure over the epigastrium or umbilical region for around 10 to 30 seconds. You press over the right hypochondrium. Observe the JVP. A sustained rise in JVP during abdominal pressure indicates right heart failure. So usually it is taken as a rise of more than 3 centimeters. Sustained rise that is occurring more than 3 centimeters is taken as a positive hepatojugular reflex, previously called abdomino, or better called as abdomino-jugular reflex. So you press on the abdomen. So when you are pressing, what happens? The venous return increases. A patient with a heart failure is unable to accommodate the blood, so the pressure rises and that is transmitted. That is a mechanism of the hepatojugular or the abdomino-jugular reflex. What are the conditions where you can get a elevated JVP? Right heart failure, congestive pericarditis, cardiac tamponade, tricuspid regurgitation, when there is a fluid overload. So I have previously told you JVP is always pulsatile. The exception when is a superior vena cava obstruction, or the height of the JVP is too high, then again the upper level of the JVP may not be visible. So one of the important point of JVP is that JVP has a definite upper level. If the JVP is too much elevated, the vertical column is inside the skull and you will not be able to see the JVP. In superior vena obstruction, again you will not be able to see the pulsations and the upper level cannot be seen. The changes in the V wave and some of the named abnormalities in the JVP, like Frederick sign, will be discussed during the next session.